With a warm welcome and encouragement, we hope that the program we prepared for you will be fruitful and engaging. Before we get started with our program, I would like to hand it over to Professor Chen Weijian once again to introduce our keynote speaker. Professor Chen is also served as the director of the Center of Neuropsychiatry Research. He has served the society with his expertise and committed to substance abuse prevention for many years. Let's welcome Professor Chen.
Okay. Today, I have the honor to introduce keynote speaker, Dr. Philipe de Souto Barreto. And Professor Barreto got his Master of Science in Physical Activity and Health from International University of Andalusia. And then he got his PhD in biocultural anthropology from Marseille University. So that's the very unusual combination because you got physical activity and bioculture and anthropology. So now he has been the director of the Institute on Aging and Gerontology, Toulouse University Hospital, and then become a professor in 2018. So today, he also will talk about very unusual topic. I mean, generally in public health, we seldom talk about the appetite, but his topic is the appetite in the context of the integrated care for older people program, data from the Toulouse real-life implementation. Now, let's welcome Professor Barreto.
Thank you for the introduction. Great pleasure to me to be here today in front of you to have the opportunity to make this talk. Big thanks to the organizing committee for inviting me. Hopefully it's my first but not the last time that I come to discuss with you guys. Very, very happy to be here. So I will talk about today appetite in the context of the ICO program of WHO, using the data we have been collecting in Toulouse for a few years now. Here are my conflicts of interest before starting. So the ICOP program, Integrated Care for Older People, is an innovative healthcare pathway. It's innovative because it's function-centered and person-centered. Traditionally, in Western countries, we have a healthcare pathway that allowed a lot of good things for the health of the population, like increasing life expectancy, based on a single disease-centered approach. So the traditional model, you have here an example, we are looking for people that will develop, for example, Alzheimer's disease, and we try to treat the disease. In the ICOP model, the difference is that we are not looking if the person has Alzheimer's disease. I'm not saying it's not important, it's really important, but we are looking for function, cognitive function. And once the function is declining, even before any disease phenotype appears, this can be treated using the different approaches we have, including pharmacological and non-pharmacological approaches. So we are going from a traditional model based on a single disease treatment to a new healthcare pathway that is based on function and person-centered. Here we have a few of the main concepts embedded in this ICOP healthcare pathway. So the idea is to promote healthy aging, and here you have the definition provided by WHO in the report published in 2015, the World Report on Aging Health. That's the process of developing and maintaining functional ability. So functional ability is in the heart of the healthcare pathway. And functional ability is composed by intrinsic capacity, the environment, and the interaction between intrinsic capacity and the environment. Intrinsic capacity is the composite of all the physical and mental capacities of an individual. So a very nice example that John Beer, that was a previous director of WHO and that was one of the most important guys in publishing this report, he's always give this example. Intrinsic capacity is your vision acuity. Environment is, for example, when the interaction between the intrinsic capacity and the environment is when you put your glasses and you can see better. So this is functional ability. That's the interaction between intrinsic capacity and the environment. So in Toulouse, the ICO program has been implemented, especially putting an initial emphasis in the step 1 of the ICO program. I will show you the steps of the ICO program with the 6 essential, let's say, operational domains of intrinsic capacity that you can see here in this figure in the right side. So we have locomotion, cognition, psychology, hearing, vision, and the vitality domain. The target population are people 60 and older, even if intrinsic capacity is developed to be evaluated in even younger individuals, middle-aged, but the ICO program is more appropriately developed for people, older adults. This vitality topic is the most unconsensual one. The vitality domain is the one that is harder to define, but it has been often operationalized through nutritional aspects in older adults. These nutritional aspects in the screening part are defined by weight loss and appetite loss. So here you have the pathway of the ICO program. It's for the moment a 5-step program, but this will probably be changing in the very short future. In the next handbook of ICOP, we will probably have another structure for the healthcare pathway. But for the moment, from the publication done by WHO in 2019, this is still the structure. So we start with the screening for potential deficits in intrinsic capacity, all the domains I showed you before. So people that are screened positive here goes to step 2. We have an in-depth assessment of intrinsic capacity, but also looking for potential causes of the declines in function. Third step, go into the personalized care plan that's defined with the patient, and so on for the step 4 and 5. Here you have the screening tool of ICOP. So the tool that's used in the step 1. As you can see, it's composed of very simple questions for all of the 6 domains of intrinsic capacity. Questions are very simple tests. For example, for cognition, you have time orientation and you have word recall that most of you know from the mini mental state examination. For locomotion, we have the 5 chair rise from the chair as fast as possible. So very simple tests that can be done in primary care in general. So in Toulouse, we have been implementing the ICOP in the real life of the healthcare system since January 2020. So we have almost 5 years now implementing this program. Toulouse region, it can be seen here in red. It's in the southwest part of France. Now this initiative I will show you is being spread in the whole country. After a few years of a success story of implementation in Toulouse, so the Ministry of Health of France decided to do an experience involving other regions of the country as you can see here in the screen. And this started 2 years ago. So now the program is being implemented in several parts of France. In this experience, a very good point to raise is that since this is funded by the Ministry of Health, the healthcare professionals that are implementing ICOPE in the real life of the healthcare system are being reimbursed for their work. So if the person does a step 1, you have a reimbursement. For step 2, you have another reimbursement. So this is something that's really important to help healthcare professionals changing their behavior in the daily life, because it's hard to ask a healthcare professional that has, 20 years of career doing a way. Well, tomorrow for older adults, you change the way you are doing and you do like that. It's not very easy to change behaviors. And having this support, political support with specific funding is really key for helping this new implementation. So this is how it works in our setting in Toulouse. So we have developed, in collaboration with WHO, an app that's called the ICOPE Monitor, and a conversational robot that is providing the evaluation of the step 1. We have seen that some older adults, especially young older adults, likes to have the conversational robot to have this interface, to have this data collected, but most of them are using the app too. So this app is different from the WHO app in the way that it is looking for longitudinal data too. So all the data we are collecting over time is being stored in a secure database. So we need to create the whole digital infrastructure, which was a very hard work to be done. So we create this database that is receiving all the data. There is an algorithm that will generate the alerts when there is a positive screening in the step 1. The healthcare professional in charge of the patient receives this alert, and at that moment they can look at the step 1 to see if a step 2 is appropriate. Sometimes the step 1 is just an acute problem that don't need necessarily a step 2. It would be just waste of time for the patient to come to the facility, for the healthcare professionals to evaluate them. So there is a first, after the screening, a first look at the data, and eventually even contacting the patient to see if this patient should be invited for a step 2 and give the next steps in the healthcare pathway. And then those who are invited come to the facility for the step 2 and the development of a personalized care plan, step 3 in the ICOPE program. Knowing that all this data is collected continuously, and we in Toulouse have access to explore this data set, and I will show you a few papers that have been published on that. The other side of the digital infrastructure of this database is the interface for the healthcare professionals. So this is very simple interface here with a few tests. These are not true patients. This is what the healthcare provider has as an interface. Once the person is evaluated in the step 1, the patient will come to this data set. You can click on the name of the person, and we'll have the results for each of the domains of intrinsic capacity with a very simple color code that indicates if the person has a positive screening or not. In longitudinally, if the person have had a new positive screening or is just stable, or if the person has improved his or her step 1 screening. So very simple to use by the healthcare professionals. And these are very recent data of this initiative in Toulouse. So for the moment, more than 6,000 healthcare professionals have been trained to ICOPE, and have downloaded the app iCope Monitor, which shows that it's really entering into the healthcare system in this area. More than 6,000 people have been evaluated with at least the step 1 by healthcare professionals. And here you have a few elements about the 74 years in average, and mostly women. You can see that cognition has been receiving higher positive screenings, followed by hearing, vision, psychology, locomotion, and the lower prevalence is for vitality. And in the right side, you can see also that we are stimulating self-assessment. It's a way also to empower older adults to take care of their own functional health. And we have more than 11,000 people that are doing self-assessment using these tools. Self-assessment for the step 1. And as you can see, they are a bit younger than those who are being evaluated by the healthcare professionals. But the structure of the positive screenings will be quite similar, with higher positive screenings for cognition and then the other domains, as you can see. One of the first publications we have done on this data was performed in Lancet Health Longevity a couple of years ago, and in this publication we show the whole structure of the iCope implementation in the Toulouse area. And what's interesting to see also is that not everybody that's having a positive screening in step 1 is going to step 2, otherwise we would have too many people in the facilities, because almost 100% of people have at least one positive screening. In Toulouse, I think it's in the beginning, more than 9% of individuals have a positive screening. We cannot ask all these individuals to come to take step 2 in the healthcare facility. So that's why we implemented a professional working team before inviting people for the step 2. And we can see that 10 to 12% of the individuals with a positive screening in the step 1 will truly go to the step 2 and have the next steps in the program. So now I will just show you how we can play with this data in this data set. That's a large amount of data, as you can see. Having as an example the appetite loss topic, that's one of the screening questions for the vitality domain in the integrated care for older people. So using this data set with data abstracted in October 2023, we have done a few analyses here. You see people 60 and older. We are focused on these individuals. We have more than 30,000 people that have received a step 1 following the structure that I showed you before. Once the step 1 is done, data goes to the data set, to the database with the alert and so on. Knowing that more than 60% of these individuals that are responding to the step 1 also accept to participate in studies, other studies that we could be developing. So we have the approval to contact them if we have new studies to be developed. So again, you have the screening tool for the iCope program, and you have here the prevalence for the more than 33,000 individuals for vitality. We have 21% prevalence in this data. And we can just look at how the domains overlap with each other, because they often overlap. They are not coming alone. For example, appetite loss is overlapping with weight loss in a way that half of people with appetite loss also have weight loss. We can also look at how appetite is overlapping with locomotion. So you see that more than 50% of people with appetite loss also have a locomotion positive screening in the ICOPE. The same for for psychology, more than 60%, and for cognition too, more than half of individuals also have a cognitive impairment, those of appetite loss. And here are the figures for the sensory domain, so vision and hearing. So we can say that people with any nutritional deficit, appetite or weight loss, half of them, more than half of them have impairment in locomotion, 6% on cognition, 6% also in psychology, vision, and half on hearing. Specifically for appetite loss and weight loss in the bottom of the screen, you can see that the prevalence for locomotion and psychology, the overlap, is higher for people with appetite loss compared to weight loss. So we can see almost 6% of individuals with appetite loss also have locomotion impairment, and almost 7% also have a psychological impairment. And we always know that psychology and appetite loss are really very close together. We can also have a more data-driven approach for this data. So this is a paper that we have published a couple of months ago in Nature Aging, in which we applied latent class analysis to look at how the screening data create clusters. And we obtained the best fit for this data is the creation of 4 different clusters. One cluster that's composed by people with low probability of having impairments in intrinsic capacity, a cluster composed by cognition, locomotion, hearing, and vision, a cluster for all the domains of intrinsic capacity with a positive screening, so impairment in everything, and a cluster composed by psychology, vitality, and vision. And as you can see here, people with all impaired intrinsic capacity have a higher probability of having frailty, ADL limitations, and IADL limitations, activity of daily life, compared to people in the low impairment cluster. And what is interesting for this presentation is also the cluster containing vitality, that's the nutritional aspect. And you can see a very similar associations with people in this cluster having a higher probability of frailty, ADL, and IADL limitation compared to the low impairment group. When you look at this data longitudinally, so we will confirm that people in the cluster with all elements impaired, all domains of intrinsic capacity impaired, will worsen in frailty and ADL and IADL disability. And for the vitality group, let's say, there is also an association with worsening not, it's incidence, with the incidence of frailty. So people without frailty at baseline who will develop frailty over the first year, belonging to the cluster of impaired vitality, that's the lower in the bottom of the screen, increase the risk, the probability of having an incidence in frailty. We can also play with this data by looking at the incidence, the reversibility, and the persistence of the positive screening. So the incidence is when people don't have the impairment at baseline, but will develop the impairment at follow-up. And here the mean follow-up is 6 months. The persistence is when people have the problem at baseline and continue having the problem 6 months after. And the reversibility is when you have it at baseline but don't have at follow-up, right? And you can see here that the locomotion domain is characterized, for example, for a very low rate of reversibility and very high persistence, which means once you are impaired in locomotion, you have big chances to continue impaired in locomotion because it's very hard to revert this phenotype. And this is true for young older adults, people 60 to 79, and also very old people, 8 and plus, in the bottom of the slide. And in people 8 and plus, what's interesting is that the persistence of cognitive impairment is also very high, which means that when you have locomotion and cognition together, this is a phenotype that's really hard to revert. Knowing that this is real life data, which means that people that were observed with an impairment in an intrinsic capacity domain received counseling and perhaps even interventions from the healthcare professionals. But even with that, it's hard to revert the phenotype. And here you can see the vitality domain. That's the domain composed of the nutritional aspects, appetite and weight loss. And you can see that for the vitality is the contrary. You have a very high reversibility rate and a very low persistence rate. And this is confirmed whatever the age, the person, 6 to 79 or more than 80. What's interesting to see, and I will show you, is that the vitality domain is always appearing together with the psychology domain. Looking at this data in a longitudinal approach with people that have complete data at baseline and 6 months after, we can see that people that were belonging to a cluster in which we have impairment in locomotion and cognition at baseline, they will continue belonging to a cluster with locomotion and cognition at follow-up, as you can see here. Whereas for the vitality domain, people belonging to a vitality domain at baseline, the majority of them will not belong to a cluster with vitality, showing again this reversibility of vitality and psychology too. It's hard to know if this reversibility is because these people received an intervention for the healthcare system, or if just not stable because these are somehow subjective measurements. These are questions from a screening tool. We can also play with this data by looking at different phenotypes of appetite loss. So here we have people without appetite loss and without weight loss, people with only appetite loss, people with only weight loss, and the phenotype composed by both appetite and weight loss. And we can see how these different phenotypes associate with all the other domains of intrinsic capacity. Very interesting to show that both appetite and weight loss will be associated cross-sectionally with all the impairments in the other domains of intrinsic capacity: locomotion, cognition, psychology, hearing, and vision. With the phenotype composed by both appetite and weight loss potentializing, increasing in a synergetic manner this association with an increased probability of having impairment in the other domains. Appetite is, again, very closely related with the psychology domain, as well as weight loss, but the association of appetite with depressive symptoms is still stronger than the weight loss association with the same domain. In a longitudinal way, knowing that all the models I'm presenting to you are adjusted for age, sex, and weight, in a longitudinal way, so looking at people that didn't have at baseline impairments in locomotion, cognition, psychology, but that have developed, so the incidence of impairment in these domains, we will see that appetite, weight loss, and appetite plus weight loss are all of them associated with the incidence of an impairment in locomotion. And for appetite specifically, we also have an association with the incidence of depressive symptoms in people that at baseline didn't have this problem. So if you have appetite, declared to have appetite loss at baseline, you have an increased probability to develop in the future depressive symptoms and also impairment in locomotion. We can also look at the data using the step 2 assessment. So the step 2 in ICOPE is the full-length scales of the intrinsic capacity domains, which means the full assessment So if we look here in people, the same phenotypes, without appetite loss, without weight loss, only appetite, only weight, and both weight and appetite loss, and we look at how these phenotypes associate with the domains of intrinsic capacity, but using the full-length scales for locomotion, the short physical performance battery, for cognition, the MMSE, for psychology, the PHQ-9 questionnaire, and MNA for the nutritional status. You can see that, again, appetite is closely related with most of them, with a very strong association with PHQ-9, that's the psychology domain once again. This is cross-sectionally. Longitudinally, we didn't find any association, knowing that, as you can see, in the number of people, sample size here is quite smaller than when I presented before using the step 1, because everybody is not going to the step 2, so we don't have a step 2 to everybody. If you look to the associations with frailty by using the Fried score, or the screening of sarcopenia with SARCF, or with full-length scales for ADLs and IADLs, you can see again that appetite is being associated with a higher severity in all these clinical outcomes. So people with appetite loss compared to those without appetite loss and without weight loss, they have worsened frailty, bad scores in SARCF, but also IADLs and ADLs. And there is also a longitudinal association with frailty worsening. We can do the stratifications by sex, female and males, and we will find exactly the same trends with the associations of appetite loss with all these health outcomes. For females and for males, it's quite consistent throughout the data set. We can also stratify according to the age of the participants here. So people young, older adults, 6 to 79, and people 8 and plus, and you find quite similar results. So appetite loss is consistently associated with the clinical outcomes, regardless the sex of the individual or the age range. And you can also look at different phenotypes of appetite. I really think that appetite loss is an umbrella syndrome in which we have several different phenotypes. We can have appetite loss with weight loss or without weight loss. We can have appetite loss with depressive symptoms or without depressive symptoms. We can have it with and without frailty, for example, with and without malnutrition. And I'm not sure all these different phenotypes needs the same interventions to be cared, and that they have a similar consequence for the health of the individual. So using this huge kind of data set, we can look at some of these phenotypes and see how they associate with other clinical outcomes. So just as an example, if we look at the phenotype of appetite loss with and without malnutrition. So you see that a very small fraction of people have both appetite loss and malnutrition as measured by the MNA, mean nutritional assessment, only 3.5% of the population. And what you see here is that appetite continues to be associated, appetite loss continues to be associated with frailty, screening for sarcopenia, ADL and ADLs. Weight loss will also to some extent be associated with these elements. But when you look at appetite plus malnutrition, you see that this is a truly synergetic association. So for many of the association, it's not adding the importance of appetite loss plus the importance of weight loss. It's really exponentially increasing the strength of these associations. And again, quite consistent throughout sex. Females and males will have quite similar associations regarding this phenotype with all of frailty, sarcopenia, IADL, and ADLs. Again, for age stratification, the results are quite consistent. So if you are a young, older adult or older adult, people 18 plus or 6 to 79, the results are quite similar. And you can also look at another phenotype. Here we have appetite loss and depressive symptoms. So you see that here we have much more people in this phenotype. So a lot of people with appetite loss also have depressive symptoms. And here we have 15% of our population that belongs to this group. So which comes first is hard to say, appetite loss or psychology, the depressive symptoms. It's probably bidirectional, and we have some data that I'm not presenting today, but showing that if you take appetite loss, you have high risk to develop depressive symptoms in the future. But if you take depressive symptoms at baseline and people that have good appetite at baseline, people with depressive symptoms also increase the risk of developing appetite loss in the future. So probably bidirectional association. So let's go to this phenotype with people with appetite loss and depression. And you find really very similar results that I presented before. Appetite will be associated with several of these clinical outcomes, frailty, sarcopenia, ADL, and IADL. But when you go to the phenotype, appetite loss plus depressive symptoms, you have a synergetic effect. So the severity of these problems are really increased in people with appetite loss plus depressive symptoms. And very consistent according to the sex of the individuals. We will find same results for, or quite similar results for men and women. And according to the age range of people, so young older adults and very older adults. So this is just to show that the data we present here for the whole population, if you take subgroups, you will find quite similar results showing that it's quite robust associations. So this is clinically very interesting, very important, but appetite is not only defined by clinical issues. Appetite is a multidimensional syndrome that can have a very multifaceted etiological process, and some of these etiological cause comes probably from biology. And why not thinking in appetite loss as also kind of consequence of the pace of age in terms of biology. People that have an accelerated aging process, biologically talking, probably could be at increased risk of developing appetite loss, not only appetite loss, but also other age-associated clinical consequences. So having this idea in mind that the pace of aging is probably leading for several different clinical conditions that are well known to be associated with age, like non-communicable diseases, several of these diseases, geriatric syndromes like frailty, sarcopenia, falls, and many other processes, and of course, intrinsic capacity declining intrinsic capacity. In Toulouse, we have created and launched very recently this year in April, a new institute that's called the IHU HealthAge. IHU stands for Institut Hospital Université, University Hospital. In France, we have very few of these institutes, and the only one that's totally dedicated to aging is in Toulouse and was founded by the Professor Bruno Velas as founder-president. Professor Bruno Velas, who has been president of the International Association of Geriatrics and Gerontology. And this institute was created with this idea to connect the biology of aging to the health aging agenda. So looking at the hallmarks of aging, the main biological drivers of the aging process, how these biological drivers can affect intrinsic capacity, and also, of course, the whole ICO program when implemented in a real life. So integrating gerosscience to health aging. And gerosscience, most of you already know this field, very recent field in the broad domain of gerontology. And gerosscience was created a few years ago. I think the first paper is 2013, with two main observations. The first observation is that aging is the major risk factor for most chronic diseases and loss of function. I think we have always known that, right? I remember 25 years ago in my undergraduate studies, my teachers, my professors were already talking about that. So we know that. What's quite new is the second observation, is that aging can be biologically manipulated. And this is new because for many years, I think, we have made a kind of confusion between the time that's spent in life, which is chronological age. We cannot touch on that. It's impossible to revert that. But aging as a biological process can be manipulated to accelerate the process or to just make the process slower. And this is the main hypothesis of the gerosscience field, that by manipulating biological aging, we can prevent, revert, or reduce the severity of many clinical conditions associated to the aging process, including disease, but not only, also functional decline. And this is what our institute is doing now. Here you have the example of one of the investigations we are developing that's called the INSPIRED cohort. The INSPIRED cohort is a human cohort. We have human and animal studies. In the INSPIRED translational human cohort, we have almost 1,200 people from 20 years to more than 100 years, all of them quite well phenotyped, and with a very important biobank that I will present you, because this cohort is really done not with an epidemiological viewpoint, but more with a biological viewpoint to investigate how aging biology can be connected to the trajectories of intrinsic capacity in the future. We have started this program 2019, so we are now in the fourth wave of data collection for most people. In parallel, we have also animal studies with a huge cohort of mice with more than 1,500 mice, and also a colony of killifish that's a quite interesting model for studying aging, because this fish, that's the African killifish, is the vertebrate with the shortest life expectancy in the world. So this fish will be born, develop, reproduce, and die within 6 months. So this reduces a lot the time to investigate aging. And what's very nice is that all these species, we can also investigate the hallmarks of aging, the biological determinants of the aging process. So coming back to the human part, in this INSPIRE project, we can see that we have a huge biobank being collected, not only by biofluids, such as blood, plasma, and all this, but also with cells. We have cells from blood, PBMCs, but we have also biopsies from the skin and the creation of a fibroblast biobank that's being undertaken here. And by the end of the 10 years, this is a 10-year longitudinal study that's currently ongoing. And by the end of the 10 years, we expect to have more than 600,000 biosamples to be utilized. And all of these will be made available to the scientific community. So in the very short future, all of the world you can apply to have access to the data, to the biobank, if of course all this is approved by a committee. But it's not close to Toulouse. It's something that will be open to the scientific community. And we started looking at different biological drivers of aging in this data set. So for the moment, we have already done DNA methylation and the several epigenetic clocks that are available in the scientific literature. So we have first generation, second generation of epigenetic clocks, and you have even created a new epigenetic clocks that's trained on intrinsic capacity. And those that were present in this year meeting of WHO, the Clinical Consortium on Health and Aging that is finished yesterday, could see a presentation by David Furman in the Buck Institute that worked with us on this program and that has developed this new epigenetic clock trained on intrinsic capacity. Very interesting because this clock is trained on function, but it performs better, for example, in predicting mortality, better than PhenoAge or GrimAge. PhenoAge being developed and trained on mortality themselves. So it's an epigenetic clock developed on function, but that goes beyond. We have also the inflammatory clock that has been published in Nature Aging a few years ago. All of this is for the whole sample. All 1,000 people have this information. For mitochondrial function, it's a fraction of participants that are doing a single cell approach for the PBMC. So we are looking at the single cell level of PBMCs, how the mitochondria works in terms of bioenergetics. Very recent and cutting edge approach for this data that will be published. The first paper, hopefully within a few weeks, it has already been submitted. And for the very near future, we will do the SASP phenotype for cell senescence. SASP is a pro-inflammatory phenotype associated to senescent cells. And this will be working, it's in progress with people in the Mayo Clinics, especially Nathan Leber, sir, that's working with us on that. And we'll also have markers of organ health and aging. For example, here you have the example of the brain health. We'll have p-tau protein 217 for the whole sample, and also other markers like neurofilament light chains and so on. And we'll have also for other organs. So the question of appetite as a potential clinical consequence of reduction of acceleration in the biological aging process, it's in my opinion, a very interesting topic. We started a work that's still ongoing, looking at how these epigenetic clocks, the inflammatory clock, and potentially mitochondrial bioenergetics could be associated with appetite loss. And in the near future, the idea is also to look at the interplay in the biology of appetite and the biology of aging to see if we find some interesting research questions to be developed and then eventually even inform the development of new therapeutics, because as all of you know, we have no pharmacological approach to appetite loss to the moment. But hopefully it will be changed very quickly. And here is an example on how the neuroscience field could be contributing to aging. So this is very newly published data from guys from Pfizer, published in the New England Journal a couple of weeks ago. And they are looking at a molecule that all of those working with aging and that have already read something about biological aging have already listened about, heard about this molecule that is growth differentiation factor 15, GDF15. The GDF15 is a molecule that is considered as a molecule of stress of the mitochondrial stress, but is also associated with inflammation and so many other cascades, biological cascades. And here in this work, they have developed a monoclonal antibody for GDF15 that binds in the GDF15 in the blood, avoiding that the GDF will go to the receptor, that's the GFRAL that's located in the brain. And GDF15 is well-known anorexigenic molecule, so increased levels of GDF15 leads to reduction of appetite, reduction of weight. And by avoiding that this molecule binds to the receptor, they investigated several different doses of this molecule, and they could see very nice results in this phase 2 study, showing that you have an increase in weight in people with cancer cachexia. This is very specific population of people with cancer cachexia. In these individuals, those taking the drugs will have an increase in weight within 12 weeks. This increase will be somehow proportional to the level of the dose, with higher dose leading to higher increase in weight, whereas the placebo will continue losing weight in this study. Very interestingly, people receiving the highest doses of this molecule will continue having this positive effect on weight, even in several different subgroup analyses they have done. As you can see, very consistent results. And still more interesting to me is that the effect is not only in weight, but receiving this drug improve the weight of people with cancer cachexia, but also improve their appetite as measured by specific tool. I think here it's the snack, if I remember well. And also spontaneous physical activity. So people were equipped with accelerometers, and they could see that the level of physical activity spontaneously increased with this molecule. So this is an example on what we can imagine about this new approach that it can be put into this higher umbrella of gerontoscience approach. So I have a few take-home messages for you. One slide of take-home message from for the ICO program itself. So there are several positive aspects with the integrated care of older people. I'm not saying it's a perfect program, it's under construction, continuously under construction. Each time we apply this in the real life of our healthcare settings, we have new ideas and new possibilities to improve the program. But there are positive aspects. The first one is that it's fostered by WHO, and like that, this has a potential to be implemented all around the world. We have a shift from the disease-centered approach to a function-centered approach. And those who deal with older adults, and all of you deal with older adults, you know that people don't care really about having hypertension or another disease if it's well controlled, but they care really if they have locomotion to do what they have reason to do, and the same for cognition, having the ability to do things that they always have done and wish to continue doing. We have also a shift from the dichotomy, the disease, to a more continuous approach, and for me as a researcher, this is one of the most important changes, because we will be looking at function more as a continuous variable, which means that when there is a decline, even if this decline is not associated with any phenotype, any clinical aspect, this decline means already something. You are already at increased risk to develop bad outcomes in the near future. And this also means that you are not looking at people 75, 80 years, but you are looking at a life course perspective. So what is happening throughout the life of the person. And I hope is feasible to be implemented in real life. So here I present you a few data that we have developed in Toulouse. We have more than 61,000 individuals that have received and have been registered in our database that have received evaluation in the ICO program, and even more than 11,000 that have done self-assessments, so self-screening, which is an important tool for empowering people about their own health, functional health. In terms of appetite loss, this phenotype, loss of appetite, associated to all the other domains of intrinsic capacity, which shows that it's a kind of domain that is feeding all the others. And I think, in my opinion, this should be seen with very carefully, because for the moment, loss of appetite is not really implemented in the clinical practice of most healthcare professionals around the world. Loss of appetite is a good predictor in our data set also about the incidence of loss of locomotion and also psychological domain, which means increasing depressive symptom severity over time. And I think this is a very interesting field of investigation. There are different phenotypes for appetite. So we presented data of appetite loss with weight loss, appetite loss with depressive symptoms, appetite loss with malnutrition. And if these different phenotypes are being associated to different clinical outcomes remains an open question. But what we could see is that all of these phenotypes associated to major clinical outcomes. So this deserves to be investigated more in depth. And the interplay between the biology of aging and the biology of appetite loss is also a big interrogation. We don't have much data on that, but I think it's also a field that we could invest some of our knowledge and time to be developed. Appetite loss is, for me, potentially an early marker of declines in functioning overall. The extent to which it may also be a marker of accelerated biological aging is currently being investigated, and I'm quite sure that in the near future we will have very, very nice data on the biology of the interplay between the biology of appetite and the biology of aging, and to try to disentangle some of the questions that we have on this topic. So with this, I would like to thank you again for the invitation. Thank you for your attention, and I will be happy to respond to your queries. Thank you.
So thank you for Professor Barreto's very excellent talk. And we still have a couple of minutes. Anyone like to ask a question? I'll allow you first, and then Professor Xu.
Thank you, Philippe, for a very comprehensive talk. So I have a question about the oral function. So if we think about the appetite loss in older people, I think one of the key issues is oral function. But in the ICOP, there's no assessment or screening for oral function. Last time in Geneva, in the WHO conference, I insisted that we should include assessment of oral function or oral frailty. But I don't think in the revised version of ICOP, they have no plan to include oral assessment. So what is the strategy of the WHO or ICOP in the future in terms of the oral assessment?
Yeah, very nice point. I mean, of course, oral function will be major for this field. It's not implemented yet in Toulouse, what we are doing, not in the healthcare system. The healthcare system, it's not implemented yet. In the research setting, we are trying to develop an axis of research around appetite, and one of the elements will be olfactory sensory, but also oral function with the investigations around dysphagia. And in this way, I think it's quite interesting because appetite will somehow overlap with sarcopenia, right? Because dysphagia is probably one of the signs of sarcopenia. And I think it deserves indeed more investigation, but for the moment, we are far from what should be done. But in the research setting, we are starting to do it very shy yet as an approach, but we are starting to do it. But in the healthcare system, it's not yet
And appetite loss is very multifactorial. Appetite loss is multifactorial. So in addition to poor oral function, medications and other comorbidity have an impact on the appetite. So I think it's important to assess the medication and baseline comorbidity for the intervention for approach for appetite loss. So any strategy for appetite loss management?
We have this information we have. We have the information on comorbidities and all the medications people are taking. And this not only in the research setting, also in the clinical setting, because in the French system, we have a database that shows all the expenses and all the exact medications, examinations, visits to the doctor each people is doing when it's paid by the Social Security. So all this information go automatically to a database that can be connected, for example, to the ICOPE database. We are working because it's not so easy in France to connect the data sets due to the sensitivity of the healthcare data, but we are working to have this data set connecting function to all these elements, like you said, medication, hospitalization, diseases, but also expenses to look at, is this being cost effective or not? Even if it's not a trial, but I think it could provide some very nice information also in this perspective that's one of the most important for the decisioners, politicians that will take the final decision to fund or not. So this is possible, yeah. And we are working on that.
Yeah. That last one is, although you mentioned about there's no drug for the treatment of anorexia aging, but in Asian countries, some Chinese herb can be useful to increase the appetite in older people. So maybe in the future we can collaborate to use the Chinese herb to increase the appetite in Western countries as well.
With pleasure, yeah. I appreciate the collaboration.
Professor Xi and then Professor Keller.
Yeah, thank you for your very excellent talk. And I also very impressed by you implement a very successful ICOP in the community. Over 61,000 participants in the step 1 screening. But I wonder, what is the next? You mentioned that only 12% of them come to the step 2. Not mentioned for even the step 3 for the intervention, right? This situation is very similar in Taiwan. We have screening for several hundred thousands elderly people in the community. But the key point is that how to implement the intervention for this test positive. Especially, I saw your slide saying that the cognitive function positive is about 48%. What can you do for this positive cognitive function impairment?
Yeah, very, very important question. What we need to keep in mind is that this is a screening, and somehow the screening is not converted in true phenotype, right? So we are not letting people aside just with the screening and we forget about. We are looking at them more deeply. There is a multi-professional team that works on each screening that call the patient to see the need to have them doing the step 2 or not. And this can be, for example, for vision, that in the beginning, the way the question is done in the screening of vision in ICOPE, almost everybody will have positive screening because almost everybody with age has declining visual acuity or are taking medications for diabetes, hypertension. And this is the question currently. So almost 100% people are having that, but some of them are already followed by an ophthalmologist, and there is no point to bring these people to the facility if they have already the good follow-up in terms of medical care. And that's what we are doing. So you have the positive screenings, but some of them have already been treated or are being treated. So that's why they are not coming to the step 2. This is one of the major points. After, for sure, there are people that are having a positive screening that have a true decline, but for any reason cannot come to the step 2. This can be a reason related to the person themselves or with the staff being overwhelmed with older patients already, and something must be done for that. But just to reassure you that most of these people are not coming to step 2 because they are already receiving the intervention.
Where's the kid?
I just want to congratulate you on a wonderful program, the ACOPI in France. A question about the appetite and not being associated or not the overlap with MNASF or MNA. It would suggest it's overly sensitive and not overly specific, right, in terms of appetite being an indicator of malnutrition. Is there a thought to think about a second stage of screening that actually might help triage people properly to the second step a bit more? And then my second question was around nutrition, because you identified appetite weight loss is very common. What specifically is happening to those step 1 people that trigger that? Is there some sort of education being provided to them? Most of them are probably not seeing a dietitian, I'm assuming, so that care is not happening, unlike the other areas you talked about.
Yeah. For the people that are having this problem, the most used intervention, as I remember, I'm not making part of the team dealing with the patient, right? I'm just taking part of the team that's looking at the research aspect. And the most prevalent intervention is just nutritional counseling for these individuals. I don't know if some of them will probably receive oral nutritional supplementation, that can be related with other aspects of their care. For example, sarcopenic people will receive protein supplementation and all this. But I'm not sure that there is much than that. And appetite loss is so hard to deal with. Every Monday, I'm having an informal meeting with some of the physicians just to let them tell me what they are seeing in their practice. And one of them that's leading the team of long-term care people, that's Professor Yves Roland, some of you know him. Yves was telling me appetite is so hard because you see patients in the long-term care that will not eat. They say they have not good appetite, but when they go with their family to a restaurant, they eat a lot. And so it's a very hard topic. So I don't know what can be done, but for the moment, what has been done is more supplementary nutritional counseling for these people.
Yeah, I'm just wondering if a portion of those people, self-management could be done, right, through nutrition education, rather than seeing a healthcare professional might be very expensive, right?
Yeah, it could be a very, very great point to develop the educational aspect of these individuals. I can't tell you if how well educated they are. We have not collected this data, but I think, it can be a strategy to be tested.
Okay, so we are going to the last question.
Okay.
Yeah, thank you.
Thank you, Dr. Barreto. My question is, how do you collect the data information of appetite loss? Is it simply a subjective answer response from the subject, yes or no? Or can you suggest any other in-depth indicator to confirm the appetite loss?
Yeah. For the moment, in the healthcare aspect, it's the ICOPE question. So it's the ICOPE screening question. So you have a single question that I think comes from the mean nutritional assessment. You have appetite loss, yes, no. In the research setting, we are implementing from the wave 3 onwards, the SNAC questionnaire that provide a bit more information on the severity of the appetite loss. But for the healthcare, it's a yes/no question for the moment.
Okay, because of time, but as you can see, there are intense interest about appetite in this audience, but people can ask you during the break. So we need to close this plenary section. Thank you.
Professor Philipe, could you please remain on the stage for a while? We appreciate your input and sharing your insightful research outcomes with us. So could we invite our moderator, Professor Chen, representing the organizing committee and NHRI, to express our gratitude by presenting a certificate and a small gift. Please come to the front of the stage.